Let me ask you this. Have you ever experienced headaches that are pressure like a band sensation around your head, along with blurry vision, particularly if you sit up too quickly or you bend down to pick up something and come back up, if your vision goes blurry, with a pulsating sound in your ears, like almost like water or a swishing sound, like whoosh, 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 with your heartbeat? Well, if you've had any of these symptoms, you may, and I say may, you may have a condition known as idiopathic intracranial hypertension, also known as IIH for short. Well, to learn more about IIH, I've invited one of my colleagues who's a leading neuro-ophthalmologist, Dr. Valerie Elmalem, to join us on the IQ podcast. So stay tuned if you want to learn more about IIH. Welcome, everyone, to another episode of the IQ podcast. I'm your host, Dr. Rani Banik, and through this podcast, you'll learn insights about vision health and brain health to help you raise your IQ. Today, I am so excited to introduce our guest for this episode, Dr. Valerie Elmalem.
Thank you. Thanks for having me.
Yeah, welcome, Dr. Elmalem. So Dr. Elmalem is an associate professor of ophthalmology and director of neuro-ophthalmology at New York IIH of Mount Sinai Hospital System. She is very involved with teaching medical students and residents, as well as educating her peers at national meetings. So we are so honored to have you with us today. And I always like to start off by asking our guest, Dr. Elmalem, what was it that inspired you to go into your field? So was there like a particular moment or patient that you'd seen that made you want to pursue neuro-ophthalmology as a subspecialty?
So I always loved neuroscience. Even growing up, I was always a fan of science in general since I was very little. I think maybe around 4 years old is when my parents told me that I became interested in medicine in general. I don't know that there was necessarily any specific event that made me interested, but initially I wanted to pursue neurosurgery because I liked anatomy and I really liked neuroscience. And then there was actually a surgeon in medical school who told me to look into ophthalmology and told me that there was a lot of neuroscience involved in ophthalmology and a little bit of an easier lifestyle.
Absolutely.
So when I did my rotation in ophthalmology as a medical student, everybody was so happy with their field, and the patients were very grateful for being able to have the gift of sight. So I still wanted to integrate my interest in neuroscience and became interested in pursuing neuro-ophthalmology.
Well, that's wonderful. And I'm so glad you decided to pursue ophthalmology and neuro-ophthalmology rather than neurosurgery. It's wonderful to have you as a colleague. You know, Dr. Elmalem and I actually work side by side at our hospital. So it's really a pleasure. So Dr. Elmalem, for today's episode on the IQ podcast, we're focusing on this condition known as idiopathic intracranial hypertension. It's a mouthful, but we call it IIH for short. Can you give our listeners a general overview of what is this condition, IIH? And then we'll go into some more of the details. But just give us first like an overview, like a 30,000-foot view of what this is.
So idiopathic intracranial hypertension is a neurologic condition where you have elevated pressure in the cerebrospinal fluid, so elevated intracranial pressure, and this pressure gets transmitted to your optic nerves, which are the nerves that connect the eye to the brain. And when the pressure is high, it causes swelling of your optic nerves, and this can threaten vision. This condition is common in younger women in their 20s, 30s, and 40s who are overweight. And we don't know the exact reason why we have an association with being overweight, but we know that with weight loss, this condition often improves and even goes away. And some of the treatments are targeted towards lowering the pressure in the cerebrospinal fluid so we can relieve the pressure on the optic nerves.
Well, thank you for that. That was so enlightening. So you mentioned that this condition is associated with high pressure in the brain. Now, there are other conditions also that may cause similar symptoms or high pressure in the brain as well. So how do you distinguish between IIH versus some of those other conditions that may potentially be not just vision threatening, but even life threatening? How can you tell the difference?
Right. So, as part of the evaluation in someone who has swelling of the optic nerves, we want to see if they have any other conditions other than idiopathic intracranial hypertension. And that could include a tumor, like a brain tumor, that could be increasing the pressure or even causing direct pressure on the optic nerves. It could be a blood clot in the veins that drain the fluid from, the cerebrospinal fluid, and that can cause a backup and a buildup of pressure.
Mm-hmm.
So we look for those conditions by doing an MRI of the brain with contrast so that we can see if there's a tumor there. And we also do an MRV or an MR venogram where we look at the blood vessels, the veins that drain the fluid from the cerebrospinal fluid. And we can tell if there is a tumor or a blood clot that could be causing the increase in the pressure. And if we don't see those things, that's when we think about idiopathic intracranial hypertension.
So basically, you're saying, Dr. Elmalem, that the patient has to undergo these specific tests before we can call this idiopathic. By the way, for our listeners, idiopathic means we don't really know what causes it. So there's an unknown there. There's no specific cause. I wanted to ask you a little bit about, IIH has been known by many different terms in the past. And one of the terms we commonly used to use for this was pseudotumor cerebri. So can you tell us a little bit about pseudotumor cerebri, what that entity is, and whether we still use that term sometimes, or how is it different than IIH, or maybe there's overlap? Can you shed some light on that?
Yeah, there are people that still refer to it interchangeably with pseudotumor cerebri and idiopathic intracranial hypertension, but the term pseudotumor is problematic because it is the term pseudo is basically saying like. So they're saying that it's behaving like if you have a brain tumor, and I think that term can be a little bit scary for patients. And it doesn't necessarily refer to all of the underlying conditions that can cause swelling of the optic nerves. So there are still people that refer to it as pseudotumor cerebri, but I think the more accepted term is idiopathic intracranial hypertension. The other term that it used to be called is benign intracranial hypertension, and we definitely do not use that term anymore because it's not always a benign condition because you can lose vision from it.
Yeah, I think that's so important for people to realize. And hopefully that term benign has really fallen out of favor. I know that there are still some perhaps older practicing doctors who still use that term, but it certainly is not benign because it can cause not just vision issues, but other neurologic symptoms as well. Let's talk about just specifically, so now we're just talking about idiopathic intracranial hypertension. You mentioned some of the risk factors. What are some of the symptoms that can happen that patients may experience with this condition?
Yeah. The most common symptom is headache, which occurs in over 80% of patients who have idiopathic intracranial hypertension. And the specific type of headache that you get is worse when you wake up in the morning. And the reason for this is because you've been laying down all night. So the pressure in your head is a little bit higher when you're first waking up. So sometimes this headache can even wake them up from sleeping. It's usually a pounding or throbbing headache. Some people will complain of pressure behind the eyes. And then the other common symptom you can have is a swishing noise in your ears, which can occur around the same time as your heartbeat. So we call it pulsatile tinnitus or pulse
Mhm.
tinnitus.
So
And
not,
this,
sorry to interrupt, but not like a high-pitched ringing in
right,
the ears. This is a different type of sound, correct? Because a
yeah,
lot of people have a high-pitched ringing in the ears. It's very common.
right, exactly. And I'll usually ask people if they hear sort of like the sound of the ocean. Uh,
Mm.
it's more of a swishing than
Mhm.
the high pitch ringing or buzzing that you may get with tinnitus that can be associated with ear problems. Another symptom that you can have is more common in people who have more swelling of the optic nerves, which is called transient visual obscurations. What
Mhm.
this is when you change position. So if you stand up quickly, or if you come to a sitting position from laying down, sometimes you can get a temporary blackout or whiteout of the vision that lasts just a couple seconds and then comes back. Some people will describe seeing spots in their vision instead of this blackout or whiteout of
Mhm.
vision, but they're temporary changes in the vision that occur due to swelling of the optic nerve. And this is because of the pressure on the blood vessels supplying the eye from all that swelling.
Yeah.
And
Just last week, actually, I saw a patient with newly diagnosed IIH, and she described she would have these transient blackouts whenever she bent down to either like tie her shoe or pick something up off the floor. She would bend down for just a few seconds, get back up, and everything would just be gray and pixelated. And then her vision would come back into focus. So, again, positional changes are really key there.
right. Some other symptoms that people can have, they can have dizziness, they can
Mhm.
have neck stiffness when the pressure is really high. Um, and rarely, but it can occur, you can have some changes in concentration or cognitive changes that occur with the high pressure.
Absolutely. Now, I wanted to talk a little bit more about the headache because many people get headaches of all kinds, whether it be tension headache or migraine headache. How can one differentiate headache that's from high pressure in the brain that may be from IIH versus a migraine? Are there specific symptoms that they should be watching out for?
Yeah, so as I mentioned before, the headache that is associated with the high pressure very commonly can occur when you're laying down, um,
Mm-hmm.
or right when you're waking up in the morning. So if your headache is worse right when you wake up and then it goes away after about an hour or two when you've been standing for a while, that can be a symptom to look out for. And sometimes people have worsening headache when they're changing position, like if they're bending down, as you mentioned, when with your patient who had the change in vision with
Mm-hmm.
bending, the headache can also get worse with changes in position. So this is as opposed to migraine, where it can occur at any time of the day, and some people will get a warning sign that they're getting a migraine, like some zigzags or changes in their vision, or
Mm-hmm.
they'll get pain, behind one eye, and then it'll spread to the other side. And they usually will get better with certain types of medication, but can be associated with nausea, light sensitivity, and sound sensitivity. So there can be some overlap with migraine. So many people who get idiopathic intracranial hypertension are young women, and young women also commonly have migraines. So there certainly can be overlap, but the differentiating feature is the headache will get worse with changing position. And I think if
Yeah.
you have that, then that's something to really look into.
Yeah, those are some great tips, Dr. Elmalem. I've actually had a lot of patients who have had a previous diagnosis of migraine for many years, or perhaps, a new diagnosis of migraine. Then they slowly notice that their headache changes in its characteristics, and they ultimately get diagnosed with IIH. So it is possible to have two together, both of the conditions together, but many patients can differentiate the type of headache that they're getting, like, oh, this is my pressure headache versus,
Right.
oh, this is my migraine headache. So you just really have to pay attention to your symptoms and maybe, keep a log, jot them down, and try to identify the pattern that's happening that may help you identify the cause. So Dr. Elmalem, you talked earlier about a couple of tests that need to be done to diagnose this condition, IIH. So you mentioned, like, for example, MRI, you mentioned spinal tap. What about vision tests? Like, from a neuro-ophthalmologist perspective, which vision tests do you rely on the most to help monitor these patients and watch their vision?
Yeah, so we will check the vision on the eye chart, the visual acuity.
Mm-hmm.
We will do a peripheral vision test called a visual field, where we test not just the center, but also the peripheral vision, because commonly in idiopathic intracranial hypertension, the first vision to be affected is actually the peripheral vision, not the center vision. So many times people won't even know, they won't even be aware that they have peripheral vision loss until it gets closer to the center. And then, it's later on in their course, and we really want to catch it early.
Mm-hmm.
The other test we look for is color vision, because in optic nerve conditions, you can have decreased color vision when it's a little bit more advanced. And we also do some pictures of the optic nerve. One of the pictures that we rely on mostly to tell if things are getting better or worse is the OCT test, which is optical coherence tomography. This is a picture where we can actually measure the thickness and look at the configuration of the optic nerve to tell if there is worsening or improving swelling.
Mm-hmm.
And by the configuration of the optic nerve on this test, we can also tell if there is high pressure, like the cerebrospinal fluid, that's kind of pushing on the optic nerve to change its configuration, moving up rather than the normal configuration, which is down.
Mm-hmm.
So we really rely on this test heavily for first diagnosing and also for following patients with idiopathic intracranial hypertension.
Well, thank you for sharing those. So again, just to recap what Dr. Elmalem said, we check vision, we check color vision, we also check pupils, and we check the field, which is very, very important. And perhaps the most important test that we do is we monitor the peripheral vision, and then we do imaging of the optic nerve, such as an OCT test, and sometimes even photographs of the optic nerve to document how much swelling there is. Welcome back, everyone, to the IQ podcast. Today, we're chatting with Dr. Valerie Elmalem, a leading neuro-ophthalmologist and expert in IIH. So, Dr. Elmalem, we've talked about what may be risk factors for IIH, what it is, what the symptoms are, what the findings are on eye exams. Now, let's talk about treatment, because I know that's what people want to know about. How can I take care of this? Can I make it go away? What can be done? So when you first see a patient, what are some options that you consider for treatment for IIH?
The treatment options that I discuss with patients really depends on their vision and also the amount of swelling of their optic nerves. So we have a grading system for the amount of swelling of the optic nerves. And just, to give you an overview, you can have mild, moderate, or severe swelling. And in the more mild category, where people do not have any changes in their peripheral vision and they have normal vision and relatively mild symptoms, sometimes I will consider just advising a low salt diet and weight loss as treatment. And then I follow them closely to see if they're getting better. The next step up would be to add on a medication called acetazolamide, which is a water pill, a diuretic, that decreases the production of the cerebrospinal fluid to decrease the pressure. And we still also recommend the diet and the weight loss, the low salt diet and weight loss, in addition to using the acetazolamide. And we can start with a lower dose of 500 milligrams twice a day, and then increase based on their response or how much swelling they have.
Mm-hmm.
If they have more severe swelling or if they have significant vision loss, they're not going to be able to have enough time to wait for these other treatments that take longer to work. So we need to do something quickly to relieve the pressure on the optic nerves, and that will often include some kind of surgical treatment.
I wanted to go back and touch a little bit about some of the points you made earlier. For mild and even moderate vision loss, we usually recommend weight loss is kind of the mainstay of our treatment. Can you talk a little bit more about the weight loss? Like, what are your recommendations for people? And also, secondarily, what if someone is not overweight? What do you recommend for them? So I guess they're kind of two separate questions, but let's talk about the first one and then the second one.
Right. So where we get the amount of weight loss, kind of our magic number, really is by looking at previous research studies with people with this condition. And there was a research study in the late 1990s looking at people who had idiopathic intracranial hypertension and weight loss. And they found that the people who had 6% of their body weight loss, were the ones who had the most improvement in their symptoms and in the swelling of the optic nerves. So that's kind of the magic number that we recommend for people to aim for. And for most people, I mean, that's 6% is not a huge amount of weight. For many of the patients who have idiopathic intracranial hypertension, this can be somewhere between 10 and 20 pounds. So it is something that's difficult, but is attainable. We're not asking people to lose 100 pounds, you know.
Mm-hmm. Absolutely.
And in the patients who have normal weight, we definitely will look for other conditions that could potentially cause idiopathic intracranial hypertension. So we didn't discuss this earlier, but there is a whole list of medications that can actually increase the intracranial pressure. And this can include acne medicines, such as the tetracycline family, like minocycline and doxycycline. So we will ask if they're on these medications. Even sometimes retinols that are used in skin creams for acne treatment can cause an increase in the intracranial pressure. The other thing that I ask about is vitamin A supplements. So if you're taking the recommended daily value of vitamin A, that's fine. But some supplements have mega doses of vitamin A, and this can also lead to an increase in the pressure. So I will go through their whole list of all their supplements and their medications, and to make sure that they're not taking something that could raise the pressure. Additional risk factors. This is a little bit controversial, but certain types of oral contraceptives can contribute to an increase in the pressure. So we always want to ask about this, but the increase is not as high as some of the other medications that I discussed, maybe a 1% higher chance. So those are not as critical to stop as the other medications such as doxycycline. The other potential risk is steroids. So using steroids, either using them for a long time or tapering off of steroid medications, can increase the pressure. So in patients who have more of a normal weight, I will ask about these medications and try to stop them to help.
Yeah. And also back to what we were talking about before to tie this all back, if we find that the patient is on a particular medication that may have put them at risk for this condition, then we know that there's a cause. Right. So then it's no longer necessarily idiopathic. And in those situations, sometimes we do call it pseudotumor cerebri because now we found why they have the high pressure. And usually when we discontinue that particular medication or supplement, then hopefully the pressure will normalize. So that's also something important. It's a small distinction, a little bit of semantics, but I think it is important to recognize that. Well, thank you for those recommendations, because I know that a lot of people, a lot of my patients who have been newly diagnosed with IIH, they will report weight gain. And many patients will say, oh, in the past 6 months, yes, I've kind of gained weight a little bit. Anywhere from 10 to 15, even 20 pounds can sometimes make a difference. And, if someone's on the edge of potentially developing this condition, it can kind of lead them over tip them over. And simply by losing those extra few pounds, that can make a big difference in getting this condition to hopefully go into remission, which is the next thing I wanted to talk to you about. Dr. Elmalem, how long do you expect people, let's say they've been put on medication like Diamox, how long do you expect people to stay on that? Like when can they be stabilized, and when can you potentially take them off the medication?
I think this is something that's very individualized. So some patients will lose weight and then their symptoms will get much better and they'll be able to stop acetazolamide after only a few months. Some patients will have a really hard time, and every time they try to stop the medication, their symptoms come back or their swelling gets worse again. And it may take more time, like maybe even a few years. But I definitely have patients who are able to stop the medication and stay off of it. And, I have some people I've been following for 5, 10 years, and they're still doing fine off the medication. So, you don't have to lose hope that you're going to be on this forever. But, unfortunately, there are a few patients that need to take it for several years. And, if you're benefiting from it and the swelling is under control and your vision is normal, symptoms are good, it's fine to take it for a few years.
Mm-hmm. Yeah, I always tell patients, the two approaches work together. So there's weight loss and the medication. So if you can achieve the weight loss goal, then we can taper you off the medications. I've also seen patients where they've successfully come off, they've lost some weight, and they've come off the medication. Then they happen to regain weight a few years down the road, and then it flares up again. So that can happen. For whatever reason, IIH tends to be very, very sensitive to weight in certain individuals. Don't you agree, Dr. Elmalem?
Yes, definitely.
Yeah.
And the other thing I wanted to touch upon with weight loss is we talk about this magic number of 6%, but there was another research study that looked at people who had bariatric surgery and the amount of weight loss they had with that. And they actually found that if they lost about 24% of their body weight, they were basically cured. So they had normal pressure. And
Wow, that's
so,
great to hear. Yeah. And nowadays, we have various options for weight loss. Now we also have these drugs called GLP-1 receptor agonists, and they have been very effective in helping people lose weight. So I've had quite a few patients with IIH who also go into remission and even cure being on some of these medications.
yes.
Yeah, absolutely. So, Dr. Elmalem, we have just a few minutes left together. This has been so helpful in understanding IIH, what you've shared. Do you have any other lifestyle tips you usually give your patients who've been diagnosed with this condition?
Yeah. So many people think that if they have to go into this rigorous exercise routine to be able to lose weight, but it's actually 80% diet. And I tell people you don't want to do it quickly. You want to do it slowly, and you want to actually just change your lifestyle. Um, and
Mm-hmm.
so, following the low salt is important because a lot of patients will find when they have a higher salt meal, their symptoms will get worse. The pressure will go
Mm-hmm.
up. So maintaining less than 2,000 milligrams of sodium per day is really important for this condition. Having slow weight loss that will be effective and stay off is important. And what has proven to really work is doing some kind of program where you're tracking what you're taking in and you kind of keep yourself accountable. You don't have to go crazy and weigh yourself multiple times a day, but I think weighing yourself about once a week so that you know your overall progress, I think it helps you stay on track. and joining some kind of program where you have other people to help support you also makes it more effective. So
yeah, no, those are great tips. And actually, I was involved in a large study called the Idiopathic Intracranial Hypertension Treatment Trial, IIHTT for short. And those patients who were enrolled in the study, they each got a weight loss coach. So they each worked with a weight loss coach during their time in the study, and it made a big, big difference to help someone guide you along the way, who also helped with nutrition and exercise or movement goals. All of our patients had pedometers, so they logged in their steps that they walked every day. So it does help. It is helpful to have someone kind of guiding you along the journey, or perhaps joining a patient support group who can guide you, or weight loss support group. It makes a big difference because then you're not doing it on your own. Well, thank you, Dr. Elmalem, for all of these amazing insights into IIH. It's really been so helpful for our listeners to help understand this condition that is just so common these days in our patient population. If anyone wanted to reach out to you to perhaps learn more, or perhaps even become a patient, how can they find you?
I have a website on the Mount Sinai website. If you just do a search for my name, my full name, Valerie Elmalem, and actually there aren't too many people with my last name. So even if you just search my last name, you can find the Mount Sinai website that has my office phone number, address, and email, and you can make an appointment through there.
Well, wonderful. We will share that link in the show notes underneath the podcast. So thank you again for joining us, Dr. Elmalem. It was really a pleasure to chat with you today.
Thank you so much for having me. This was fun.
Absolutely. And thank you all for listening to the IQ podcast. I will see you all next time for our next episode. So stay tuned.